Thank you so much for your kind introduction, Dr. Junko. Thank you. These are my disclosures, and I want to start off with a slightly busy slide. And as you know, I'm here to talk about the clinical considerations, clinical questions that we ask ourselves when we are in the consult room or in the ward, and we have a person who's been newly diagnosed with HIV standing or sitting in front of us, and we really want to start them on treatment on the same day. I think this sort of segues nicely from Professor Hong's last slide, which is what are the things that we need to think about? Is the patient ready? Are healthcare providers ready? Are we ready to say, to put pen to paper or to type in that prescription into the electronic medical record? Are our systems ready? And I think this also highlights the point that what we do sometimes is determined by the environments that we are in. Patients differ, systems differ, epidemics differ from place to place. So some of the things that I'll be talking about today may not be 100% applicable in all settings, even within a region that's limited, within a regional sort of system like the Asia Pacific. But I hope to be able to discuss, I think, several general clinical considerations that we have when it comes to same-day initiation. So this slide that I have here is a table that's drawn from the New York State Department of Health AIDS Institute guidelines, which looks at a protocol for rapid ART initiation. It's not even, strictly speaking, same-day initiation, but you can see that it's complex. It's multi-steps, it's multi-dimensional, right? It's about identifying people living with HIV, newly diagnosed with HIV, who might be ideal or suitable candidates for same-day or rapid initiation. And these, of course, would include confirming that they're HIV positive, that they've not have any other medical conditions that might necessitate deferral or a slight delay in starting them on ARTs. There are a lot of considerations when it comes to assessing people's information level or their knowledge level, their literacy level, knowing how much we need to tell them upfront without overwhelming them, so that we can pave the way for same-day or rapid initiation that is as problem-free as possible. There is establishing what tests need to be done right there and then, what results need to be known right there and then. And then there's, real-world considerations such as payments, right? Not every territory or jurisdiction comes with free access to care, fully subsidized access to ARTs, including in Singapore, where it's a co-payment system, depending on what your sort of socioeconomic status is, and then actually initiating ART and planning for future follow-ups. So I hope to be able to sort of talk about each of these steps in the next few slides I'll be talking about. So of course, the number one first clinical consideration when it comes to starting someone on antiretroviral therapy, whether it's on the same day or at some point in the future, is ensuring that they actually are HIV positive. Screening and testing for HIV is the first step, the sine qua non of starting someone on treatment. You have to be sure that they're HIV positive. You have to make sure that you have a robust testing, screening and diagnosis confirmation system in place. All of you were here for session 1 where we talked about HIV self-testing. I think that's a essential key step in getting more people tested for HIV and getting more people diagnosed. It's the first step in the HIV care cascade, the first gap that we need to close. So I think the other thing to think about when we're talking about testing and screening for HIV is ensuring that our systems are equipped to test for people for HIV when they present with indicator conditions that may point out that they are immunosuppressed due to HIV. And for this, I think the hallmark case is for tuberculosis, right? Most of our countries in the Asia-Pacific regions have robust national TB programs for diagnosis of tuberculosis, but the ability of these programs to also then screen people for HIV as a co-infection may vary slightly. So I'm first going to talk about sort of regional treatment and testing coverage. So you can see in the table on the left that at least amongst key populations that need antiretroviral therapy, the performance of our region, the Asia and the Pacific, in getting access to antiretroviral therapy, varies from population to population. Less than half of pregnant women are able to access antiretroviral therapy to prevent mother-to-child transmission. I think Brigitte talked about this earlier on in session 1, that we are lagging slightly behind in terms of preventing vertical transmission of HIV, and getting more people tested and treated early may be a key step in doing this. The colorful graph on the right is actually the performance of Singapore, right, the country that we are in right now in terms of getting people diagnosed and treated and virally suppressed. This is data from 2019, which is the most recent data that I am cleared to share, at least at a public forum. But you can see that we are very close to achieving the first 95. But getting more people tested is where we really need to put more work. And I think this is reflective of the region as a whole. Testing and screening, the faster we get results in, the faster we can tell people that they're actually, HIV infected, the faster we can start therapy and treatment. This is a screenshot, and this is a part of the national HIV program's national testing recommendations from Singapore, something that we just published hot off the press a couple of weeks ago. And it shows that, our testing algorithm, at least locally, now includes has gotten rid of the Western blot, which used to have a turnaround time of about 3 weeks, to using a HIV 1-2 immunodifferentiation assay. I'm not sure how many countries were still using the Western blot. It was something that we worked hard to sort of get rid of, but essentially what I'm trying to show here is that designing systems and designing testing algorithms to shorten the duration between someone presenting and requiring a test and being able to tell them that they actually are HIV positive is a key step in getting people on treatment more quickly, possibly on the same day if possible. Now, I talked a little bit about TB and HIV co-infection and the fact that TB is a critical clinical indicator for us to think about HIV. And if you look at the global TB incidence and HIV prevalence in new TB cases on the left and right side of the maps respectively, that our region, the Asia Pacific, is a region that is fairly high burden for both tuberculosis as well as for HIV prevalence in new TB cases. And so it's really something we need to think about, perhaps especially in health systems where the STI HIV side of the healthcare house is maybe slightly separate from the TB side of the house, then closer collaborations would allow us to make HIV diagnoses more early. So HIV testing, I think, is recommended for all people presenting with TB. But in the Asia Pacific, at least, less than half of all cases of TB were tested for HIV, at least in 2013, which is when data from this particular paper that I'm showing was drawn from. This review paper essentially showed that the TB HIV co-infection prevalence was actually pretty low in our region, but I think I agree with the authors in that it is likely due to variable rates of testing and lower rates of pickup rather than true prevalence of TB HIV co-infection. So then the second step is providing information and support for people living with HIV, and I'm drawing from the paper that Prof. Hong, Nitaya, and myself, together with a few other authors, actually published late last year. There are some considerations. Time does need to be taken when you're sitting with a patient in front of you who has just been diagnosed with HIV and you want to broach the topic of same-day or even rapid initiation. And I think taking shortcuts with any of these steps to empower individuals to make joint treatment decisions is likely to bring us less success when it comes to starting them on treatment on the same day. We should explain why it is that same-day and rapid AERT initiation is beneficial, not only to individual health, but also to public health. Time should be taken to talk about the fact that these strategies, right, same-day, rapid initiation, are not things that we have pulled out of a hat. These are things that have been studied extensively, that there's a huge body of evidence behind them to show that benefits to mortality, morbidity, as well as transmission are beyond question, right? If ART is to be initiated on the same day, I think as clinicians and together with the whole healthcare team, we have to come up with an adherence plan, telling people why they need to take their medications, what time, what things to avoid when it comes to drug-drug interactions, what kind of adverse effects to potentially anticipate, and what to do if these adverse effects actually occur. If we plan not to start them on the same day, then at least a plan for initiation over the next 1 to 2 weeks needs to be put in place. And counseling, all the stuff that we've talked about just now, does not need to be done by a clinician or a nurse who may be running a busy clinic. These are tasks that can be shared or shifted to community health workers, to peer leaders who are also trained in ART preparation counseling. And I think in one of the talks in session 1, it was really inspiring to hear the case of Vietnam, where there are so many civil society organizations, community-based organizations that actually run their own clinics, that actually run their own sort of community-based healthcare services, which is something I think Singapore can learn a little bit from. Now, apart from giving people information about treatment itself, I think that first consult where the decision around same-day initiation needs to be made is also important, because it's an opportunity for us to assess what the general health literacy of the person living with HIV is. It gives us an opportunity to know how much they know about HIV, who they plan to disclose it to, what are some of the implications of this, and also to address some of the other medical, psychosocial, and other barriers that may present themselves as challenges to treatment and adherence, such as substance use, such as any financial challenges, housing instability, and so on and so forth. Now, there are some baseline evaluations that I think are important when it comes to that first visit and that decision to be made about rapid or immediate initiation. I think most immediately, most potentially life-threatening would be to exclude the possibility of any co-infections or opportunistic infections that may become worse because of immune reconstitution inflammatory syndrome, or IRIS. I think especially when it comes to central nervous system tuberculosis and cryptococcal meningitis, where as most of us will be familiar, the guidelines recommend that we start specific therapy for the OIs first, document and be very certain of a therapeutic response, and then make a decision for ART as soon as possible. This is particularly important because if you look at the incidence of cryptococcal infection by region, you can see that the Asia Pacific is not necessarily low. We do have some regions and some territories within our region where the incidence of cryptococcal meningitis or cryptococcosis is fairly high, and hence ruling this out either with the use of clinical screening or serologic screening is going to be important, and most of the time these tests come back in a matter of hours, so should not delay the initiation of antiretroviral therapy on the same day. Now, I'll be talking about some of these other sort of baseline evaluations that may be important as well, including the HLA-B5701 status, which may impact the use of abacavir-containing regimens, especially important because abacavir-containing single-tablet regimens are not uncommonly used, including, of course, abacavir, lamivudine, dolutegravir, and other abacavir-containing regimens. The viral hepatitis co-infection prevalence within the particular region, which may impact the use of tenofovir or amtricitabine lamivudine containing regimens, what the underlying sort of prevalence of transmitted drug resistance in the region is, especially when you're considering starting someone on regimens that contain non-nucleoside reverse transcriptase inhibitors, although this is becoming less and less important with the growing prominence of the use of integrase inhibitors. And of course, baseline evaluations that may impact your choice and dose of regimens, such as any pre-existing end organ disease, whether it's kidney impairment, liver impairment. So I apologize for the small slide. With these two tables, I really just wanted to show that HLA-B5701's allele prevalence amongst Asian populations varies widely. In settings and in territories where the ethnic makeup of the population is a little bit more homogeneous, right? It's a little bit easier for us to make generalizations. So the first paper really looks, I think, emanated from China, and it looked at HLA-B5701 allele positivity in both Han and non-Han Chinese, and in both of these populations, the seroprevalence is extremely low, less than 1%. However, in the table and the paper below, which is a study coming out of South Asia, I think an Indian population, depending on the sort of the actual state that the populations were drawn from, the allele positivity or allele frequency varied widely from as low as 1-point-something% to as high as 12 or 13%, right? So in populations like Singapore and Malaysia, where you have relatively more heterogeneous populations, where you have had a large amount of migration, intermarriage, allele positivity varies widely. A paper that I'm not showing here, but showing HLA-B5701 allele positivity in Singapore varied from less than 1% in Chinese populations to about 5% in people of Indian extraction. So decisions and recommendations around testing for HLA-B5701 before starting an abacavir-containing regimen may vary depending on where you're practicing. Now, we're talking next about hepatitis B and HIV co-infection, and at least in our region in Southeast Asia, as well as other parts of Asia, the prevalence also varies somewhat, depending on which country you come from, depending on what the risk factor for HIV transmission is, whether it's someone who is a person who injects drugs, MSM, men who have sex with women, and so on and so forth. So once again, making decisions about what your first-line regimen is and whether or not you need to wait for hepatitis B serologies to come back may vary from population to population. This is just another paper drawn from the Tock cohort, which is mostly ethnically Thai and Chinese, showing that the hepatitis B surface antigen positivity in people with HIV may be as high as 10 to 11%, with hepatitis C 15%, all of which may have implications for the initiation of antiretroviral therapy on the same day. What about HIV drug resistance? So overall HIV drug resistance prevalence in Southeast Asia also varies from territory to territory, from jurisdiction to jurisdiction. Some countries within our region have a low to high prevalence of HIV drug resistance. Other countries a little bit low, which may reflect various factors, whether it is the prevailing use of specific regimens, healthcare resourcing, and also, of course, drug resistance surveillance in the first place. This is a paper, these are just some comparisons showing that at least in South and Southeast Asia, published data tends to show that transmitted drug resistance, so drug resistance that occurs in people who are at least, as far as we know, treatment naive, newly diagnosed, never been on HIV treatment before, tends to run on the lower side, less than 10%. However, this comes with the caveat that we may not be screening and surveilling everyone equally, and that this may be some element of underreporting. More worryingly, however, and I will need that to come up. Okay, more worryingly, however, when we compare two different time periods from 2009 to 2013, so this is a table on the bottom half of the screen, versus the 2014 to 2019 period, we see that overall rates of transmitted drug resistance, whether it's due to nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, or even more worryingly, protease inhibitors, have actually risen over time. And this does have implications for recommendations around regimens that we are using, especially in situations and settings where first-line regimens still include NNRTIs. So other impacts or other clinical considerations that arise when we thinking about choice of antiretroviral therapy regimen when we are starting someone on treatment, especially on the same day, include being able to choose something that has a high genetic barrier to resistance, a high degree of forgiveness that we know we can be pretty comfortable giving someone, especially when they're really new to the game of being on a medication for the rest of their life. We need to consider the possibility of prior exposure to ARVs, although this should be screened out in the initial consult or the initial interview. We need to know what the local rates of transmitted drug resistance are, which I've talked about already. We need to consider the fact that there are higher rates of hepatitis B co-infection in the region, and hence the use of tenofovir-containing regimens may be more important. The potential for drug-drug interactions, especially in patients who may be older, have other comorbid conditions, and hence experiencing polypharmacy. And of course, increasingly, the use of pre-exposure prophylaxis. I think we are just about on the cusp of the era of long-acting prevention, right? And we know from the long-acting cabotegravir studies for prevention that there were some implications for developing integrase inhibitor associated resistance-associated mutations, and this limits the ability for us to use integrase inhibitor-containing regimens at least before a genotype resistance test comes out. So all of these things need to come into play when we are designing a regimen. So when we look at countries and regions in the Asia-Pacific, what the regimens are, a bit of a busy slide, but I think what you can appreciate is that almost all of the countries that we highlighted in our paper, in Taiwan, Thailand, Singapore, the Republic of Korea, largely used regimens that were anchored in the use of second-generation integrase strand transferase inhibitors, together with some backbone of nucleoside reverse transcriptase inhibitors. This is the Singapore guidelines. And one thing you'll notice in the Singapore guidelines, at least in the version that is correct up to 2023, is that we still include the use of NNRTI-based regimens as first-line alternatives. And this is because ART is not free. In Singapore, there's a co-pay model, and whenever you have to ask someone to pay for it, you have to consider the ability for people to pay. And unfortunately, medicine still costs money. Newer regimens still cost more money than older regimens, and some kind of joint decision needs to be made about this, talking to your patient about the potential toxicities, the implications of starting them on an NNRTI-based regimen needs to be factored into your initial discussion. So, you have taken that first step. You have started them on therapy. They are happy with your explanation. What do we do from that point on? The most important thing to follow up with them clinically, I think, is to plan what the road ahead is going to be like. Monitoring them appropriately for their virologic and immunologic response, although, as I said, with majority of the regimens being used nowadays being highly potent, non-toxic, and highly tolerable second-generation integrase inhibitor-based regimens, we expect a good immunologic and virologic response, and we expect a low rate of toxicities returning. I think it's important that we put in place adherence counseling, as well as critically what we here in Singapore call positive prevention counseling, which means telling people not so much that they are at risk of transmitting the virus to others, but stressing the point that being on treatment greatly reduces or eliminates the risk of them transmitting the virus either onto their sexual partners, to their unborn children, or to anyone else, right? So here in Singapore, at least, we have integrated treatment as prevention and U equals to U counseling into funded targets and KPIs for hospitals, which means if you don't do it, we don't fund your programs. So we always have a bit of a stick problem here rather than a carrot problem, unfortunately. So I think the last thing I want to talk about is just that as clinicians, apart from looking at tests, interpreting tests, and writing prescriptions, we have a key and integral role in reducing stigma and reducing structural barriers. The published evidence is pretty unambiguous in showing that patients or people living with HIV who have just been diagnosed with HIV, one of the most important encounters that they have is that first visit they have with a practitioner. Whether it's a nurse, whether it's a community-based organization representative, whether it's a key population-led sort of service provider, or a physician, right? That first therapeutic encounter forms the foundation for the ongoing therapeutic relationship that people have, and hence being able to be empathetic, being able to give them the information that they need in a way that they can digest it is going to be key in designing our programs. And one of the ways that we can do this not only is through restructuring the way we see patients, but also restructuring the way we train people who see patients. And so that's where sort of clinical education, medical education really comes into play as well. So high quality counseling and emotional support is really part of this as well. So the next step, of course, would be reducing the stage from multi-step or stepwise laboratory testing, stepwise processes. I want to show the exact same slide that Professor Hong showed. So when he showed his slide, I was like, oh no, he's sort of spoiled the last slide of mine. But I think it's nice to bookend our talks by showing that we have always been sort of very conditioned or very used to providing care in a stepwise way, right? You have to cross step 1 before you can cross step 2. I have to make sure that you have gone to see the counselor before I send you to go and get your laboratory test done. I have to make sure that all your laboratory test results are back before I can make a decision about prescribing. What if we could compress all of that into the same visit in a way that's safe, in a way that's effective? It's been assessed. I think Professor Hong went through the RAPID trial, or the RAPID program, which was initially a pilot in San Francisco, but is now standard of care in that city, where we may take more time for that first visit. We may need more people there involved in that first visit, and we may demand a little bit more of not only the patient but also of the various steps in the sort of the care provision cascade. But I think the outcomes speak for themselves, not only in a trial setting but also in a clinical setting where same-day initiation really just starts people on the road to getting better much more quickly. I've come to the end of my time, and I'll be happy to take questions during the panel discussion. Thank you so much.